I am Dr. Vijay Reddy Kantula, an associate professor at University of Utah Salt Lake City. I am a practicing and consulting internal medicine physician. In this chapter, chapter 2, we will cover assessment of COVID-19 infection. The objectives of this session are to understand the clinical features of COVID-19 infection, risk stratification of COVID-19 patients, early recognition of critically ill patients. First, we look at the epidemiology and natural history of COVID-19 infection by looking at this case scenario. This patient, he got tested on Monday. The following day, he got exposed to COVID by socializing, this is on Tuesday. The results from Monday came back negative on Wednesday. So he felt good. He went out the following day on Thursday and socialized again. However, on Friday, he developed symptoms and he felt, hey, I was negative. What happened? So the next day, Saturday, he gets tested. Sunday is a holiday and they're anxiously waiting for the results. And on Monday, he turns out positive. So to explain this, we need to look at the natural history of the disease, which we will first look at the natural history of COVID-19 infection. As you can see in the graph at the bottom, the symptoms start from here. So 1 to 2 weeks before, the virus has already entered the body. This is the incubation period when the virus is multiplying in the body and the patient has no symptoms. And during this time, the PCR test will be positive, the polymerase chain reaction. Once the antibodies start developing, the first one to show up is the IgM antibodies. And this is the period, if you look at the top graph, when the antiviral response has started and probably peaks around this time. Later, the IgG antibodies also develop, and depending on which type of test is done at which point in this timeline, the test will be either positive or negative. On the top graph is the clinical features, stage 1, 2, and 3. In the initial phase, the body mounts an antiviral response, and the patient may be asymptomatic, which is true in majority of the cases. Some of them may have mild symptoms as well. In this phase, the PCR test is positive. In phase 2, about 10 to 15% of the patients may develop this. There will be viral replication and the lungs are affected. There is pneumonia, shortness of breath, and findings on chest and CT scan, chest X-ray and CT scan. A tiny minority progress into the next stage, which is the cytokine storm phase, when there is hyperinflammation as the host mounts an inflammatory response. In this phase, the patient will have pneumonia, sepsis, respiratory failure, and acute respiratory distress syndrome. And many of the patients may die in this phase. The common clinical presentations that are encountered, we'll quickly recap again and discuss in slightly in the suspected, but suspected because. So in symptomatic patients or patients with, we look at comorbidities that put a patient at higher risk. The second important one is clinical assessment, which includes screening for symptoms.
Just to recap, symptom duration and severity are also important, especially if they develop a persistent cough, fever, and a headache. And this will be associated with hypoxia if the lower respiratory tract is involved. The cough and chest pain may also be present, especially if they develop thromboembolic disease in the lungs. These symptoms particularly worsen in the latter half of first week and the early part of second week, so approximately between 6 to 10th or 11th day.
One of the important symptoms to be evaluated is
patients should be monitored closely for oxygen saturation, especially those who are at home, and ideally they should check it at least 4 to 5 times, maybe every 2 to 3 hours if possible, especially if they are high-risk patients. so that these patients can be identified early if they're desaturating. So once the saturation drops below 95%, it's in the range of 94, 93% even at rest, that is a good time to transfer the patient immediately rather than wait until the patient is very sick, in which case the patient may not respond that well to treatment. The other thing that we can also do is assess the conscious level using the simple scale. The abbreviation is AVPU. So right now you are all listening to this recording. So your status is alert. So if the patient is talking to you, able to have a conversation, coughing, and complaining of symptoms, he is A. The other end of the spectrum is unresponsive. The patient, you pinch him, you punch him, he or she does not respond. In between these are two other stages. So the patient is alert, they're not talking to you. Let's say they're not talking to you. What do? You talk to the patient, call them by name, ask them, sir, madam, what's your name? If they respond, they open their eyes, they tell their name, but go back to sleep. That means they're not alert, they're unable to have a conversation with you, but they are able to respond to verbal stimuli. If the patient does not respond to stimuli, verbal stimuli, like when you call their names, they don't respond, then you go ahead and give them some painful stimuli, and the best place to do that is pinching the trapezius muscle. Maybe you can try to do that on your own, see how painful it is. You can try it on somebody who's next to you. Okay, there is a practice which I will strongly discourage from doing, which is rubbing or the sternum with your fist, which can be very painful. It looks ugly when other people look at it. So try pinching the trapezius. If the patient responds, then they're responding to painful stimuli. If they don't, then they're unresponsive. So anybody who's in the P or U status is very, very ill. Immediate action is needed. In addition to evaluation of comorbidities and the current clinical situation, we also have to evaluate the social situation of the patient, which will determine where the patient will be managed. Is the home setting adequate and conducive for home isolation? And this depends on how big the house is, whether the patient has separate bathrooms to use, is there enough space, or there may be situations where there are 5 people living in a house and they share a bathroom. That may not be the best place for isolating one family member, in which situation the patient will have to go to a COVID care center. Also, the patient may be healthy, there may be a big house, but there is an elderly person in the house who you want to be very careful about, because we don't want the elderly person to get infection. In such cases as well, COVID care center isolation is required for the healthy person. What if there is adequate space in the house, but not enough food is available, or the patient is unable to care for self, unable to monitor their symptoms, unable to check their pulse oximeter? In that case as well, the patient needs to be in a facility. Also, if the patient is a high-risk patient, then we already know that they should be at home alone.
How to diagnose a critically ill COVID-19? We all know that vital signs stands for. Let's look at blood pressure first. Generally, we consider 120. Tachycardia is an early sign of shock. Any infection.
Mentioned bradycardia as not being a critical, as being a sign of critical illness. It could be very rarely, especially if it's because of myocardial infarctions on the right side, or other forms of bradyarrhythmias, which can be due to medications or other reasons. So don't assume that a patient with COVID infection would not have any of these acute cardiac problems. It is quite common that patients can develop myocardial infarction if they have COVID infection. So keep an eye for that if the bradycardia is persistent, especially if they are symptomatic. get an ECG or do a troponin test and have a very high index of suspicion for uh, acute cardiac illnesses.
Heart rate is, respiratory rate. Vital signs are vital. We learned why that's the case. Skin color also drops or changes. We'll spend a little time trying to understand evaluation.
Now that we have learned how to recognize and categorize patients based on mild, moderate, and severe disease, let us see what we do with them and where do we manage them. So if a patient has mild illness, we can manage them at home, keep them in home isolation, obviously if they meet the social criteria and if they don't have any risk factors. If they have moderate disease, as indicated by a respiratory rate about 24 and a saturation less than 94%, then they definitely need to be admitted in the hospital, no matter whether they have comorbidities or not. Obviously, if the patient is sick, severe, critically ill, and we have discussed some of those, what those signs are. If they have a very fast breathing rate, or the saturation is less than 90% of room air, or their mental status is in the category of P or U, P is responding to pain or unresponsive, then we should definitely think of admitting in the ICU. Also, patients with low blood pressure, severe hypoxia fall into this category. We'll discuss this more in the session on clinical management of patients.
We'll come to the end now. I hope you had a